Dr. Adam Urato, welcome to the show. It is so nice to have you here today.
It's great to be here. I appreciate the opportunity, and I appreciate being able to join you.
Oh my goodness. No, the pleasure is mine. I am very, very excited to have this conversation. You and I have been speaking back and forth, and I think that you not only have some really important information to share, but information as well that is not, I would say, well known, or I should say, like exceptionally well known still today mainstream. So I think that this is a really important one, and I am so excited to dig in. So, again, welcome.
Terrific. Yeah, I'm happy to be here, and I agree. I'm trying to get the word out on this, and it's helpful to do it through podcasts and other platforms like this.
Yeah, yeah. Well, I'm honored that you're here, and there's so many subject matters I think that fly under the radar, but I can't help but think that this is actually one of the topics that I've covered, that is really just I should say flies under the radar. It's really something that I don't hear a lot about. So before we get into everything, why don't you tell us a little bit about your work? Tell us a little bit about your practice. Share about your specialty a little bit. Also, are you still doing deliveries? All of that good stuff.
Yep, sure. So I grew up in Framingham, Massachusetts. I was born here locally. That's where I still am. And I actually work at the hospital where I was born. And I still do my specialization is maternal-fetal medicine. So I did OBGYN training, but then I focused just on high-risk pregnancies. So I do maternal-fetal medicine. And so I'm seeing patients daily. The bulk of my practice is seeing patients in the office, doing ultrasounds on them throughout their pregnancy, and then counseling them about pregnancy issues. And then I also like to still enjoy doing deliveries. That's really what first kind of drew me to the specialty was labor and delivery, and I still love to do that. I still deliver babies regularly.
Oh, I love that. So, actually, just kind of a lead-in question or a foundational question, but what, you've been doing this how long now? How long actually? I don't
I've
know
been
that.
a I've been a physician for 28 years, and I've been doing maternal fetal medicine as for 20 years.
Wow. Okay. So yeah, you've definitely got skin in the game. That's amazing. What have you seen, I think from the since the beginning to now? Like what's changed the most? Or I'm sure there's multiple things that have changed, right? But what's something that has changed the most throughout the time that you've been practicing?
Oh, it's a great question. I mean, I think directly relevant to this area that we're talking about, I've seen more use of medications, drugs in pregnancy. I feel like going back to when I was in medical school from 92 to 97. I became a physician in 97. Going back there, I think that there was more caution, more concern. I think more people followed what's known as the precautionary principle, which is to have concerns about medication exposure unless they're truly studied, well known, etc. Now it seems like over time there's been an erosion of that, and it's almost gotten to the point where people are assuming that things are safe or probably okay unless they're proven to be proven to cause problems, which is sort of exactly backwards. And I think what I've seen in my practice in taking care of pregnant women just reflects the broader society. I tell people when I lecture on this that like we take medication use for granted in our society, but we in the United States are the most human beings most exposed to pharmaceuticals, medications, vaccinations, etc., in all of human history. Like we are living in a very atypical time compared to the rest of human history, where we're ingesting all of these medications, where we're being injected with all these vaccinations. Like this was never standard before. And as we've seen this happen over time, I've seen this happen firsthand, that there are more and more exposures during pregnancy. So I would say that's one of the biggest changes I've seen over time. There are other ones definitely, for sure. One good trend I think that I'm seeing is that more and more patients, more and more the public seem to be looking into these things now, doing their own research or listening to podcasts, trying to collect their own information. And I actually think that's a good trend. I think that for some people, they feel like, and sometimes the patients joke, they'll say, I went to Dr. Google to figure this out as a joke. But I have no problem. And I think it's important for patients to look into these things, to research these things, especially when it comes to medications, vaccinations, etc. If you're going to be ingesting a chemical, a synthetic chemical compound, and that's what medications are basically. I tell people medications are chemicals and chemicals have consequences. They're not naturally occurring. They're not growing on trees. They're being synthesized in a chemical manufacturing facility. So if you're going to ingest these, you really want to have looked into them, have read up about them to know and understand what you're ingesting, or in the case of injected medications or vaccinations, what you're being injected with.
Yeah, such a good point too. It's kind of funny because it's like I feel like everything is just handled well, mainstream. Okay, so average society handled with such aloofness almost. You know what I mean? It's just like, oh yeah, well, it's just meds or it's just even over the counter. So it's like Tylenol as an example. Like, well, it's just Tylenol. It's safe. I could take it daily. And I mean,
Yes.
the people that are making the Tylenol, I said making, but like the plants or whatever you want to call it. I don't know if that's the correct word. I mean, they're probably not sitting there in shorts and a t-shirt.
Yeah,
Like
that's
they
right.
probably have like gear on, that's protecting them because they are working with chemicals. So it's crazy to say, and it's not, I mean, I get the whole like dose makes the poison type of a argument, but not necessarily all the time. What do you have to say about that?
Yeah, I think you're right on the money. I think you hit the nail on the head. People need to think about this, like where are the things coming from that I'm putting into my body? And if you look, I include this when I lecture on this, in my lecture on this, when you look at where medications are made, where they're being synthesized, they're being made and synthesized in chemical manufacturing facilities. These are chemical plants, and the workers typically are wearing protective gear. They're wearing eye protection, they're wearing body protection because they're working with chemicals. Those chemicals are coming out of that manufacturing facility, and then they're going into you when you're taking them, or in my situation, they're going into the pregnant moms and the babies that I'm taking care of. So I think it's really important for patients and for the public not to lose sight of that.
I totally agree. And it's, I think like to your point, you just said it a second ago. I think that it's on one hand, it's awesome. It's kind of like we have these two camps, like there's more medication use, more vaccinations, more this, more that than ever. But then on the flip side of the same coin, you have people who are investigative now. You've got moms who are like absolutely just like, for lack of better terminology, balls to the wall, right? About like
That's right.
researching their, for their children or, trying to raise them more holistically or really just like getting down to the nitty gritty and being advocates, for their family in a way that we've never seen before, which is awesome. So it's sort of crazy because in a way it's like there's these two extremes. You have the middle a bit, but I don't know. In the circles that I am in, I guess it's like I really can see the two extremes so much.
Yeah.
And I don't and it's sort of an interesting time, I think, to be
Yeah.
living in, right?
I see that daily in the office. I think you're exactly right. I think I see that daily in the office where you've got patients who are very well read and have looked into this, and they understand these issues relating to, for example, in the area that we're talking about, medication use in pregnancy. They're really tuned into that. But then you have other patients who are coming in who basically the only counseling they're getting on this is what's kind of known in the conventional wisdom or what's out there sort of in mainstream media. But that is what I tell patients all the time. What you're hearing in mainstream media or hearing from corporate sponsored media is going to be a message that is essentially marketing. It's designed to market the drug, and it's going to downplay any safety concerns. It's going to overemphasize or upplay the efficacy of these things, and so you're going to end up with this basically the corporate message is what's going to get out if you don't go exploring yourself, if you're just hearing that corporate message. And that corporate message comes not just on TV or in commercials, it's also typically gets promoted through the groups that are funded by pharma. And in our society, unfortunately, though that even includes or has included like the CDC, the FDA, the academic medical centers, some physicians, key opinion leaders, who are all kind of singing the same tune, what's sort of like the conventional wisdom on things, the consensus. But a lot of time that's a consensus, a scientific consensus that's basically being set or established by the pharmaceutical industry.
Yeah. Yeah. And, just to remind everybody before we go on, I mean, Dr. Urato is actually a Harvard trained medical doctor. So it's not like he's, been in the holistic space and he's just like, oh, like he's pulling this out of no. I mean, this is somebody who went through medical school telling you this. And so I think I just want to like kind of stamp the envelope there because it's true, and it's hard. And I think that a lot of doctors such as yourself, there's a good crop of doctors, you've probably seen it, who have actually started to speak out, who have actually started to, see the narrative and be like, wait a second, though, this is not right. We have to go about our practice differently. But I mean, there's still a lot of the other and a lot of and I don't think they're doing it maliciously. I want you to actually speak to this. I don't think that a lot of doctors are actually coming out here and going, can't wait to ruin patients' lives today. Like I don't think that that's the tune that they're walking to. But I think that they've been conditioned by like medicine as a whole, conventional medicine as a whole, because of these other entities that have such a grip on them.
Yeah, I think that's right. I think most physicians really want to take good care of their patients. I mean, with any profession, with any specialty, there's a bell curve of people and who are doing better, doing worse in that aspect, et cetera. But I think most physicians are trying to advocate for their patients and do the best job that they can. I think what we're all struggling against is this regulation. I would call it a regulation and information crisis that we have in our society. Like in our society, those systems, the reg of regulation and information have kind of failed. It really, what I tell patients all the time is that the public really is on one side of this and the pharmaceutical industry is on the other side. And the pharmaceutical industry is trying to sell their products to the public. But really what we should have is between the pharmaceutical industry and the public, really strong regulatory bodies and information systems to help inform the public and protect them and get the right medications to them or not. And so you'd want to really have like robust institutions like the FDA, the CDC, the academic medical centers, the physicians, the experts, the media, who are all working on behalf of the public to get this information correct to them to protect the public. But what we have instead in our society is that a lot of those information and regulatory bodies are actually being funded by pharma, so that instead of playing the role of accurately trying to inform the public or trying to protect the public in the case of regulation, they're more playing like a sales and marketing role where they're working for pharma to try to get the public to use the products and to increase sales and profits for pharma. And this is the system that all of us are struggling with, not just patients, but the physicians themselves. So I agree with you. It's not that the physicians are not looking out for the best interest in their patients, of their patients for the most part. It's and not trying to give them the wrong information. It's just that this system has become so entrenched where a lot of the information that's getting out there to patients as well as doctors is this, I would call it like the pharmaceutical conventional wisdom or the big pharma scientific consensus. So on any given area or any given topic, you end up basically getting messaging out to everybody that is from pharma, and it's going to be the focus of it is going to be designed to increase sales and profits.
Yeah. Wow. Really, really well said. I mean, it's a disconnect. And the thing is that unfortunately, it's a purposeful disconnect, but the doctors are not necessarily purposefully, going about it and going, oh, yeah, okay, I'm just in on the game. You know what I mean? Like, that's not what's
Yeah.
going on, to your point. And it's really difficult. Like, I've seen this with family, with friends. It's like they really like their doctor. Their bedside manner's great. They sing the praises, and they trust the doctor because the doctor does have this really great ability to build a rapport. And so anything that doctor says is going to go over smoothly, and they're going to trust what that doctor is saying. And again, it's like that it could be the best bedside manner experience in the world, and they still might be not really getting all the whole scope, right? Whether it's care or whether it's about a specific medication, just because the doctor doesn't have all of the information, and the informed consent is not properly being given. And that's really, really tough, because you have good people trying to do good things, but these overheads, they've got a much bigger they've just got bigger goals. And it's really unfortunate. But today, I think, if we haven't learned anything in the last 5 years, a lot of us
Yeah.
have, I mean, I would like to say that for the most part, I had my eyes fairly open before COVID, obviously more so post COVID, but a lot of people have woken up and have started asking questions and have become more leery. And to your point earlier, have started doing more research.
Yeah, I think that's exactly what happened during COVID, is that a lot of folks it became more aware, and this whole dynamic became much more transparent. This dynamic of the failure of regulation in terms of the FDA, in terms of the failure of information, in terms of what was coming out from the CDC and other bodies, it was more transparently seen by the public as almost all or a lot of it serving the interests of getting the drug into people, or getting medications into people, or vaccinations into people, to increase sales and profits, which is really what it is behind all of this, and has been for years. But COVID did that. And the other thing that happened that people became more aware of this is with the OxyContin crisis. A lot of people had their eyes opened by that, and understanding that what they're hearing from these so-called expert groups or professional medical groups is really pharma's message. If you look, for example, I think it was called the American Pain Society. They were promoting, this is going back to oxycodone, they were promoting the using pain as the fifth vital sign. So for years, physicians looked at the main vital signs, the temperature, the heart rate, the respiratory rate, as the blood pressure, as ways of trying to assess a patient. But this pain society came up and tried to promote this idea of we need pain to be our fifth vital sign. And it became this real push. And physicians often didn't realize that the push behind that was oxycodone, and was the pharmaceutical industry, to try to get people talking about pain, thinking about pain, assessing pain, screening for pain, so that they could try to identify more, basically more customers, and use more drugs to increase sales and profits. And so I think that with oxycodone, with OxyContin, and then with the COVID, the public became more aware. People's eyes became open to this dynamic occurring, where the information systems as I said, failed, and the information that people are getting, not just from the drug companies, but also from the so-called experts or professional medical groups, etc., is really tainted, and it's tainted by drug company cash.
Yeah, wow, absolutely. And you're right. I mean, there's been a huge silver lining through all this experience, just I mean, both with the example that you just provided, and also just with COVID. I mean, and there's been so much devastation, but there's been some light too, and some people have moved through it a little bit more gracefully, and some people have had a terrible time with it, right? Because it's like there's such a betrayal aspect to it, trusting a system so profoundly through your life, and then realizing, wait, they, I can't. You mean I can't just walk blindly and trust what's being told, or I can't just watch the mainstream news, and like now I have to think about, well, is that really true? or,
Yeah.
just critical thought became, just kind of came to the forefront, which I think was, I mean, even though there was so much turmoil and so much devastation, also, it's not over, by the way. I mean, it's not over. There's still a lot of fallout from it, but there's been some good as well. So, as hard as it's opened a lot of eyes.
Yeah, absolutely.
Yeah.
Absolutely. Every cloud has a silver lining, as they
That's
say.
right. That's right. I mean, and oftentimes it's not, I guess, change is not made until there is so much discomfort that is presented. And I think that there's so much discomfort, so much just turmoil, that there had to be something that was produced. We had to, like, almost just completely lose it in order to see some of the stuff uproot. So
I think that's a great point, and I think that's exactly right. I think though what you saw, the dynamic that you saw during COVID, was already in place for years with the marketing of drugs and with the use of drugs and medications and vaccinations. That dynamic was already in place, but it was never as stark or as apparent as it became during that time. Again, that and with OxyContin as well, people really becoming aware of the fact that the regulatory systems were not really protecting the public, that the regulatory systems were almost to some extent, those regulators were acting as cheerleaders to try to get pass products through and get increased use of them. And I think the public increasingly became aware of that. That dynamic was in place long before COVID, but with COVID, it became much more starkly apparent to everybody.
yeah, it's so, so, so true. It's like somebody pulled back the curtain
Yeah.
finally, right? So speaking of, as we sort of, segue into the meat of this episode, I want to ask you, because we are largely going to be talking about SSRI use, in regards to, fetal development, baby mama. But I want to ask you, sort of opening into this, was what compelled you to sort of start? Was there like a moment, I should say, where you just thought, okay, like this is not good, like this has to be talked about more? Or was it just something that was sort of, sort of a slow rise? Or did you really have a moment where you were like, I got to do something about what I am seeing?
Yeah, I think it was probably a combination throughout my medical school time and then into residency and beyond. Particularly, I remember back to in medical school when I was on the wards, seeing patients coming in and just having these long, long medication lists and thinking like, are we sure? Like, how do we know how all these drugs are interacting with each other in a given patient? And I tell the story back in those days, we would write our notes on pen and paper. Nowadays, everything's electronic, but back then it was pen and paper. And one of my chief residents, when I was rotating on internal medicine, said, when they come in, fold your paper in half, and then over in the right-hand column, that's where you put the medication list, and it'll be somewhere between like 10, 15, 20 drugs for these patients, like crazy numbers of drugs that these patients were on the internal medicine service. And I remember that really hitting home for me. I think also then as I became a resident, it's interesting you mentioned Tylenol earlier. I remember that we would often tell pregnant women Tylenol's completely safe. That was the sort of scientific consensus or conventional wisdom that Tylenol's safe in pregnancy, no issues, no problems, doesn't affect the baby. But I remember as we were saying that or hearing that, thinking like, how do we really know that? Like from the way I think about these things, again, going back to what we had said earlier, is that these medications are chemicals and the chemicals are going to have chemical effects. That's what they do. They have chemical effects. And so this notion of, well, we know that it's completely safe, that always, kind of puzzled me. And then as it turns out with Tylenol in particular, as we've studied it more, we see in the animal studies that it definitely has impact on the developing brain. And then there's also human studies that is showing impact for the developing brain with things like ADHD and other neurobehavioral problems, as well as things like asthma. So I think I was becoming more and more aware of this. And then what I do every day in my office is ultrasound. So I'm looking at developing babies all day, every day, and I'm thinking about the development. And then I'm also talking to them about their medications. And so it's always front and center for me. And I guess over time, I just felt like it was important for this voice or this sort of voice of caution to be heard. That's important to have that out there because so much of what patients are hearing and the public is hearing on different medications in pregnancy is that they're safe, they basically don't affect the baby, and that it's much more important to treat whatever condition versus being cautious about medication use. And so I think it's just important for people to remember that that message, which can be correct in some cases, but that message is a message that's kind of designed to increase sales and profits. It's not really the way we want to approach medications in pregnancy, which is with the precautionary principle and assuming that they're having some harm and some effects with each mom and baby.
Yeah, well said. I wonder there's a part of me that wonders if at one time, because I feel like almost asking the question, was profit always the main driver, like way back in the day? I mean, and I guess the answer is probably yes, if you know the Rockefeller story and the way that that all came to be, right? It's like, yeah, potentially yes. But there's also changes. So, yes, where the research and so forth was probably showing that X, Y, and Z drugs, such as Tylenol, you know, nothing is nothing is set in stone. So it's like I hear parents say, well, we gave our kids Tylenol and you guys turned out fine. And it's like, well, honestly, there's more research now. There are more people
Yeah.
looking into things now. Things can change. Nothing is really set in stone here in medicine or in life. And so I feel like, while profit in sadly has probably always been a driver, in terms of like the research or, just how things evolve in medicine overall, things change, and we need to be able to, I think, as consumers and patients and moms and dads, we need to also accept that and not be so stagnant in our thought process about meds. What do you have to say about that?
Yeah, I think you're raising a very good point about how profit plays into this. And what I try to explain is that the messages that you're often going to hear, the public is going to hear, are often the messages of buying something or consuming something, whether it's a drug, a vaccine, or a procedure. Those are the messages that are often going to get out to the public versus a message of caution or versus a message of watchful waiting. And the reason for that dynamic is because the medications, the drugs, the vaccinations, the procedures, they end up generating revenue. And that revenue can then be used to sponsor professional medical societies. They can sponsor speakers. They can sponsor key opinion leaders. They can sponsor commercials on TV. And then all of that sponsorship can lead to more use, which then leads to more revenue, which then leads to more sponsorship to control the flow of information. You might say, well, then the forces in society of caution or of watchful waiting or of not doing those things, they need to also have sponsors, but there is no sponsor because there's no product on that side.
Right.
There's no product, there's no revenue being generated on that side. So it's basically a lopsided battle essentially. The forces of intervention and over intervention and medicalization have an unfair advantage because those things lead to sales and profits, which can then be used to fuel more use of it. Whereas those of us arguing for caution or for less intervention, it doesn't generate a profit. And so there's really an unequal sort of unequal battle, I'll call a battle going on. The public needs to be aware of this. So when the public hears about, oh, this is the latest trend that I just heard on CNN that you need to now screen for this new disease, and then to make sure that you don't get it, you got to do this. That is likely getting out to you through CNN because that's going to drive sales and profits. And you're not likely to hear the opposing side on that because that's not going to generate any revenue. So the public needs to be aware of this dynamic.
Yes. Ooh, well said. Yeah, I like the fact that you actually used screen because that is, I mean, not just, it's not just about medication use yet. It's about also screening because
Right.
and that's a whole nother topic for another podcast episode, unnecessary screenings and the overuse and over intervention of screenings. But they're using fear, like you need to be aware of this. And really, it's like that's like step one to get you to step eight, which is then taking the
Yes.
medication, right?
Yes,
So
yes.
yeah, it's
Yeah, the strategy people at Pharma have already
oh,
thought about this. They're already 3 or 4 steps ahead in terms of realizing that they don't need to necessarily even be promoting the drug. And a lot of times they don't. They promote screening for this condition. There's no drug even mentioned on the commercials or in the continuing medical education class. It's just, oh, you got to be aware of this condition to screen for it because it's really important. But they know 3 or 4 steps down the line, if you do the screening, you're going to generate a customer eventually through that we can then use to sell the product to increase sales and profits. I
ugh.
wanted to just use this also as an example. A good example of this is the drug McKenna. McKenna was used for 20 years in pregnancy from 2003 to 2023. And when I was active in trying to oppose its use and get it pulled off the market, but when I lecture, people often ask me, like, what a failure that was. How did we inject pregnant women with a medication for 20 years that didn't work? And I say it didn't work in terms of preventing preterm birth. But the way it worked was in terms of generating sales and profits and revenue all along the system. And so by selling McKenna, you generate revenue. That revenue is able to be put into sponsoring research. It's able to sponsor academic or professional medical societies. It's able to sponsor physicians who then lead to more use of it that leads to more revenue. And again, as I've been saying now a couple of times, you get this positive cash cycle going. So even though the drug doesn't work and McKenna didn't work, from a health standpoint, it works from a revenue generation standpoint for a lot of people. And so, in that sense, that's why it continued. It did work. It worked financially. And unfortunately, that's what we have with our medical system. We've got a system that's working financially, but it's not actually working for health, as we've in the United States become the sickest population around while spending the most money on medications. I think we make up about 4 or 4.2% of the world's population, and I believe that we're using somewhere on the order of 50 or 70% of the pharmaceuticals. So it's just, it's crazy what we're doing. And people need to be aware of this also in their own lives and with their own health, that the system that they're living in is really crazy compared to other places and compared to the rest of human history.
It is so crazy. I'm really glad that you brought up the McKenna example because I was vaguely familiar with that. And it is so true. And to piggyback off of what you said, which I think, again, there are people in the health circles and people who are just like trying to be really intentional about raising a healthy family. You see it not just even in the quote unquote medical system. You see it in everything. These regulatory bodies. Okay, so look at like the FDA or not the FDA, but the like the well, actually, it is the FDA, but let's just take food as an example. Okay. Like there are there are so many things that are being pushed and advertised and driven and X, Y, and Z. They're not healthy for you, but they are so profitable, right?
Yes.
These chemicals or whatever it is that they're serving up in these bags and putting on the shelf that it doesn't really, and
Yeah.
people are going, well, but it's on the shelf. I mean, there's still, but I'd say average society really does walk into a grocery store and they still go in their minds, whether it's conscious or subconscious, well, it's on the shelf, so it can't be that bad. But the
Yeah.
reality is that they don't have your best interest in mind because that is not where their focus is. Their focus is just to make money, to your point.
Yes, it's so important what you're saying that the public be aware that our information and regulation systems are failed in our society so that what you're getting or what's on the shelves may not be safe or good for you. The information that you're hearing may not be accurate. It's important to keep that in mind and that the main driver of those things is profits that are there. I I try not to make it too political, but during the same time McKenna was being injected into pregnant women, the United States was involved in Afghanistan for about 20 years, and people say, how that didn't work. It didn't work. Just in McKenna didn't work. How do these things that don't work last for 20 years? But they both did work in terms of revenue generation. The military-industrial complex on one hand, with revenue generation from having a war and having this involvement, and the medical industrial complex from McKenna and other similar drugs. There's a bunch of them. So these systems, it's not just medications, it's also big food, big agriculture, big military industrial. These systems are set up basically to increase sales and profits and wealth and power for those folks, but not actually for health or benefit to the public. And I am optimistic though that things are changing or hopefully will change. I think we're seeing change. We're seeing some change certainly at the FDA, and we're seeing change in society where people are becoming, I think, more aware of this dynamic and pushing back against it. And I think a real way that's helping with this is social media, the internet, podcasts like this, where people hear these messages and can understand what actually how things actually work.
Yeah, super, super well said. Well, let's segue a little bit because this is where your passion is right now. I mean, on the side, as if you're not busy enough, right? Running a private practice, delivering babies, doing the thing, you've decided to go up against the FDA regarding specifically SSRIs. And, when it comes to baby mama fetal development, and I want to get into all of it, or I should say, I want you to get into all of it. But for those that are not super familiar, because I guarantee that there are some people listening that are not super familiar with SSRIs, I'm not going to be the one to say it because it's a long word, or I should say, it's a long set of words.
Yeah.
Can you just actually describe what an SSRI is and what does it chemically do, layman's terms here, in the body once it is taken?
Sure. So SSRI is selective serotonin reuptake inhibitor.
There we go.
And before I get into this, so I just want to say that I've been very outspoken about cautioning regarding these medications in pregnancy and in talking about them in general. But the spirit of behind this is to try to get information out to patients and the public so that they'll be informed. This gets to something you were saying earlier, Vanessa, which is that informed consent, in order, and Roger McFillin always says this, in order to have informed consent, the patient needs to be informed. And so it's a crucial first step to actually get the information out. But I just want to be clear that people understand that, like, I recognize that having a mental health issue, going through depression can be awful, and that my message of caution or my message to try to get information out has nothing to do with guilt tripping pregnant women or pill shaming them. It's none of those things. That's not what this is about. I really believe in compassionate care, and I'm doing this all day, every day in my office, in my community. So I'm not browbeating my patients. I'm not having them leave the office, feeling guilty or pill shamed or those things. That's just not where this is at. The whole spirit behind this is to try to get information out to pregnant women and the public so that women can make the right decisions for themselves and then be supported in those decisions.
Yeah, yeah, and I'm really glad that you brought it up. And I was actually gonna touch on it a little bit later, and I'm glad that you brought it up now because I think it's important. And you and I have discussed this a little bit off air, is that it's really not about, like you said, pill shaming or being. Also, this is a very sensitive topic too. I mean, mental health and the things that people personally go through, and there's just a lot of there's a lot of layers here, and it can get a little complex. And so, and I think that you're just really great, I think, at being someone who just offers that kind of compassionate care because I think that delivery is everything when we're talking about like, you know, approaching patients or people about information, and there's emotion that's, you know, it's considered, but there it's detached too, because it's just like, hey, at the end of the day, I just want you to have all of the info in front of you so that you can then make the best decision, or we can collectively make the best decision for you, as long as you're presented with all the info. And you know, there's, from what it sounds like, there's still not a lot of that going on, at least, you know, widespread across the US. And so it's important, I think, and I'm so glad that you brought that up, to establish that moving forward as we discuss this, that it really is not about shaming moms or families. It's really just the informed consent part is where your passion lies.
That's exactly right. Yeah, trying to get the information out there.
Yeah.
So in terms of the SSRIs themselves, they were launched in the US in 1987, I believe, when Prozac was got FDA approval, and that would have been December of 1987. So they've been out now for decades, and they've been used in pregnancy for decades during that time. The drug companies that rolled them out told this story about serotonin deficiency. The idea was to sort of promote this idea that depression was a serotonin deficiency, and that these drugs, by inhibiting reuptake, would leave more available serotonin, which would then address this medical problem of serotonin deficiency. This theory was, again, more marketing than science. This was a marketing theory, a marketing mechanism. And probably, I mean, a lot of people have looked at this and have not shown this biological deficiency of serotonin. Joanna Moncrief is very active these days in speaking out on this. She has a book out on this topic. And a couple of years ago, Joanna had a paper. I believe her paper came out in 2022, looking at the all of the scientific information on whether or not that serotonin deficiency hypothesis was accurate, and found that there's it's not, that information, that scientific data is just not there. So this was something basically more, as I said, for marketing, this idea that we've got a serotonin deficiency, and then these SSRIs are going to address that, curing depression. Starting in 87 and then going from there, they came into increasing use. And a lot of women that are using them are, a lot of people that are using them are women of childbearing age. So then the issues came up with, can they be used during pregnancy? And so people tried to study this through various mechanisms over time. But me looking at it and going back and looking at the scientific studies, it's fairly clear for me that these drugs are affecting fetal development and having an impact on mom and baby. And when I try to explain this to people, the main way I try to explain it is by saying that we know that serotonin itself, which is a neurotransmitter, it's naturally occurring. It's synthesized in the body. It's made by different groups of cells in the gut and the brain. Serotonin's natural, and it has a really profound and crucial role as a neurotransmitter and a cell signaling molecule. It plays a crucial role in fetal development. So that's point number one in the argument. Serotonin plays a crucial role in fetal development. And that's not something that anybody disagrees with. That's not something there's controversy on. It plays a crucial role in fetal development. That's generally scientifically accepted. Point number two in the argument is that the SSRIs disrupt the serotonin system. And that's also scientifically accepted. There's really not controversy there. They don't, going back to what I said earlier, they don't address a serotonin deficiency. That's not what's going on, but they do have impact on the serotonin system. We see this, for example, with a cell type called platelets. Platelets are crucial in the bloodstream for stopping people for blood clotting, for stopping people from bleeding. When we treat patients with SSRIs, we see that their levels of platelet serotonin go down significantly, dramatically, not just like in half, but like down by eightfold or tenfold, like they go way down. So we know that there is an impact on the serotonin system. So Point number one, again, just to review, is that serotonin plays a crucial role in fetal development. Point number two is that we know the SSRI antidepressants impact the serotonin system. So if you put those two things together, the conclusion has to be that the SSRI antidepressants will impact or will alter fetal development. And so that just looking at it from a theoretical basis, then we move to the studies, and the studies again and again have shown this. So when we look at basic science studies, looking at the impact of the SSRIs, and these are drugs like Prozac, Zoloft, Celexa, Paxil, when we look at the impact on the neuron or on the formation of the brain, they use things called brain organoid models. We see an impact when the cells are exposed to the SSRIs versus non-exposed. So we definitely see this from a common sense level. We see this from a basic science level. Then when we move to animal studies, we see further evidence showing this. So there have been lots and lots of studies now, predominantly on rats and mice, also rabbits, animal models, looking at exposing them to antidepressants, to the SSRIs versus non-exposed. And we see in those groups complications. We'll see, for example, smaller litter size. We'll see impacts on behavior, for example, in the offspring, in the pups, in particular when they grow up. So we're seeing impacts on in the animal models. So then we move from there, obviously, and people say, well, animal models may not reflect humans. What does the human data look like? And the human data also is showing impacts in pregnancy. And I can walk through those individually, what we're seeing. So early in pregnancy, we see increased rates of miscarriage. This corresponds again to the theoretical model, which is that serotonin plays a crucial role in early pregnancy development. Serotonin plays a crucial role in development of the early embryo, and the SSRIs disrupt the serotonin system. So it wouldn't be surprising to see increased rates of miscarriage. And that is, in fact, what we see in the animal studies with smaller litter size and with pregnancy loss. And we do see that in the human studies. We also see increased rates of birth defects. Again, the same model. Serotonin plays a crucial role in cardiac development and in development of other organ systems. The SSRIs affect that serotonin system. We see an impact in birth defects. We see increased rates of heart defects, and we see increased rates of other birth defects. This is best known with Paxil, which seemed to have a particular problem with higher rates or significantly higher rates of birth defects. But we also see it with the use of the other SSRIs.
Wow.
Moving forward in the pregnancy, we see increased rates of preterm birth, and we also see increased rates of low birth weight. There seems to be an impact. We know the placenta has serotonin receptors, so there seems to be some impact on the placenta as well as in general on the pregnancy and on the baby that leads to these increased rates of preterm birth and increased rates of low birth weight. Preterm birth in particular is a concern because babies that are born early have much higher rates of morbidity and mortality. A lot of the neonatal problems that we see are due to prematurity. So this is a major issue with preterm birth.
Wow. Wow. Wow.
Then and then moving towards more. There's more here, and then
Yo, no,
moving.
I was gonna say there's more. And also, can I? Well, actually,
Sure.
I don't want to get ahead of you, but I don't want to lose my train of thought. And maybe I'll give
Yeah.
you a break for a second
No,
too.
no. Go ahead. Give me a break. Let me have
Yeah,
let me have some
get some
water.
water, get some water. But I had this like tagged in my head, and I don't know. I mean, I'm no expert, but I was thinking. You're probably going to get to this. You're probably going to get to like post birth and things that unfortunately sometimes are experienced, which is like post hemorrhaging, right? So
Yeah.
my brain went to when you were talking about the platelets dropping, that probably has a correlation with mom hemorrhaging. And also, I feel like you told me when we chatted weeks ago something about how that incident rate is actually much higher than people think. So, do you think that there's a I mean, I would assume there's a correlation to some degree between SSRI use and post-birth hemorrhage?
Yeah, that very important point, and that was what I was moving toward. That's right. Yeah, but yeah, postpartum hemorrhage is an important one. We know that the SSRIs affect platelet serotonin, and we think that that's the mechanism for causing increased rates of hemorrhage. And this isn't specific to pregnant women. We see this, for example, in the general surgery literature. We see this in the orthopedic surgery literature. We see this in the ear, nose, and throat literature with surgeries. Patients who are taking an SSRI have higher rates of bleeding. They have higher rates of bleeding in a variety of areas. And again, we think it's likely secondary to this impact on platelets, although that's not 100% certain, and maybe in other impacts as well. But for pregnant women, we know this is a problem because postpartum hemorrhage is one of the major causes of maternal morbidity and mortality. Postpartum hemorrhage is a huge issue in obstetrics, and these medications have a significant impact on platelet function and on hemorrhage. It's surprising though, as we've been talking about through this whole episode, through this whole podcast, a lot of doctors, a lot of patients, the public isn't aware of this link between the SSRI antidepressants and hemorrhage, which has been shown. And I tell people because I deliver babies, like when you're a woman and you're delivering, you want to make sure that your platelets are working as well as possible. And as an obstetrician and as a surgeon, when I'm operating on someone and she's bleeding, I'm hoping that her platelets are working as well as possible. These medications appear to interfere with platelet function. And so it's something that patients need to be aware of. Fortunately, the FDA has put this warning onto the label now. So if you go and you look at the label on Zoloft or on Prozac, the other SSRIs, you will find a warning about the increase in postpartum hemorrhage. It took them a while to get there, but they did put that on there. This was put on before them by the UK agency, but this is now well known, well established, I should say, but not well known. And I think, again, this really speaks to the fact that there's a lot of lack of information for patients and the public on these things, which is why I'm so passionate about this and trying to get the word out. Like, if a pregnant woman is going to be taking these, she should be aware that there's an increase in her risk of postpartum hemorrhage from being on these medications.
Yeah. This is just kind of an off the cuff thought, but when you said, it's like postpartum hemorrhage is a huge issue in your practice, or I should say, just the general practice itself. I'm just not wondering how many people are just shocked by that alone, because people often think, myself included, well, it's 2025. Like, the rate at which moms, survive is exceptionally high today. We don't really have to worry about that much. But generally, and recently, I've actually heard, and as obviously you mentioned it to me as well, that that's actually not the case. And so I wonder too, I guess my second sort of mini thought there is how much of it is actually affected by medications, pharmaceuticals such as SSRIs, or are there other things at play too? Obviously, the answer is yes, but I wonder like what the percentage is, or would you know? Do you have any statistics on that?
Yeah, you're asking a really good question. It does seem that postpartum hemorrhage rates are increasing. It's hard to know because people are measuring it differently, paying more attention. Is that the phenomenon, or is it in fact increasing? Probably it's some combination of both.
Yeah.
But it's a constant worry. I mean, this is what we worry about on labor and delivery. This isn't like a rare occurrence. We're worried at every delivery about postpartum hemorrhage. This is something that's always on our mind, always in the forefront of our minds. And so it's absolutely a concern. And with increasing rates of medications in pregnancy, certainly with increasing rates here, we have seen increased rates in general in postpartum hemorrhage. How big a contributor it is to it, it's hard to know. It's hard for me to say. It looks like in the United States, about 5 to 10% of pregnant women are on SSRIs during pregnancy, which is a fairly large, number compared to the rest of the world. In Europe, those numbers are probably more like Europe or Canada, 2 to 3%. So we're higher. We have higher rates than the rest of the world. It's interesting though. This is an area I'm going to get into in a sec, but when we look at something like neonatal jitteriness, this is the baby coming out and being jittery. There's a group of researchers recently, I think it was from New Jersey, they just published this about a month ago, that looked at the impact on neonatal jitteriness of the SSRI antidepressants. And they found that there was a ninefold increased risk in neonatal jitteriness for the babies who had been exposed to SSRIs during pregnancy. Now, ninefold risk is just off the charts when it comes to scientific research, because that's an odds ratio of 9. When we have an odds ratio of 1.5, that's relatively high, 50% increase. When you have an odds ratio of 2, you've got like a doubling, 3 tripling, like those are high rates. A rate of 9, an odds ratio of 9, which is what this study showed, is just off the charts. And the authors to this paper concluded that the SSRIs were contributing heavily to the overall rates of neonatal jitteriness that we're seeing. So I bring that up as an example of what the impact is. What the precise impact of SSRI use has been on postpartum hemorrhage, I can't say, and I don't think anyone's teased that out, but it is for sure a risk factor. The Lancet, which is one of the leading medical journals in the world, just recently did a review paper on postpartum hemorrhage, and they did point this out, this link between SSRI antidepressants and postpartum hemorrhage as one of their key or important risk factors for postpartum hemorrhage. So that concern is definitely there.
That is that is a staggering number. I'm still, I mean, for those who are not watching, my eyes have been like just super like saucers because I'm just like, that's unbelievable. But it brings me back to what you said earlier, which I think is something we all need to keep in mind, regardless, not just moms and not just, if you're pregnant or if you're trying to conceive, but chemicals have consequences no matter what it is, right? Whether it's Tylenol, an SSRI, an antibiotic. And that doesn't mean, never take a drug. It just means that there's going to be a risk benefit there. And sometimes there is a lot of risk and we're not being taught about that risk. But that's an astounding number. 9. Like
Yeah, ninefold increase. Yeah, absolutely.
that is
Yeah,
wild. That is
yeah,
so
and
wild.
and we see this because of the impact. These are chemicals that you're taking. I think you're right to again focus on that for people. They're not they have a chemical impact. That's what chemicals do. Chemicals have a chemical impact. And I just want to point out here, some people have corrected me or said, well, water is a chemical. But when I'm referring to chemicals, I'm referring to synthetic chemical
Right.
compounds. So similar to what we say just in general conversation, like if someone tells you, be careful, there's a chemical spill outside of that office, people aren't thinking that they're going to look down the hallway and see water on the floor. They're not thinking it's water. When we talk about chemicals, we're talking about generally synthetic chemical compounds. So that's what I mean by that. They're being manufactured in a chemical facility. They're not naturally occurring. And when we take those in, when a pregnant woman takes them in, they virtually all of them cross over into the baby, and they affect mom and they affect fetal development because chemicals are going to have chemical effects. I mean, that's what they do. They have chemical effects.
Exactly. Wow.
And in
Wow.
fact, in this area, I would say, just to add more to the point, is that it really speaks, this whole idea of chemicals having chemical effects really speaks to how the public hasn't been getting the full story on these, in particular with regard to pregnancy. Because when doctors are talking to women of childbearing age who come in with depression, again, they're not pregnant, they're women of childbearing age, but they'll tell them, look, these medications we're going to give you, these SSRI, this Prozac or this Zoloft, is going to have a chemical effect in your brain. It's going to help correct this deficiency that you have or this condition that you have. We now know that's not true, that that's not what's going on, but this is kind of how they're sold to the public, that the medication we're giving you is going to have a chemical effect on your brain, correcting a problem and making you feel better. But then when the women are pregnant, like you picture the doctor telling that to one woman and then going into the next room to talk to a pregnant woman, and she asks, is this going to affect the baby? And the answer we have been giving is no, it doesn't have any effect on the baby's brain. But the absurdity of that is patently clear to anybody. If it's having an effect on the brain, on the mom's brain, if that's what in fact is going on, that it's having an effect, and it is having an effect, it's not correcting a deficiency, but it is having an effect. And if it's having that effect, then it's certainly having a chemical effect on the baby's developing brain as well.
Yeah, yeah. No, I'm so glad you brought that up because I was going to ask you that as well. Like, what is the average rhetoric that's been given or the average information that's being given to just, a mom who's going in, who is either on, well, there's a couple things too, like even women that are weaning down or women that are like thinking about starting that. I mean, there's all kind of a scope, right? So it's like,
Yeah.
what is the information that's being, the average information that's being given? And it doesn't sound like it's that much other than there's not really that much of a risk.
Yeah, I have women still coming into my office, and I think this is what really motivates me. I see women every day, every week who come into my office and tell me that the only advice or counseling they got on this was that the medications are safe and they don't affect the baby. That's often all of the all that they've heard about this, and that's just incorrect and it's inadequate to be just providing that kind of information. It's important for the patients to get the whole story on this. Unfortunately, and this speaks to what we've been talking about throughout our conversation, it speaks to the informational and regulatory failures in our society that this is the information that's getting out to pregnant women and women of childbearing age, that this is what they're hearing. There was a sort of story that was spun, likely by pharma and then by the key opinion leaders. And that story is that depression is like diabetes, and the medications like Prozac or Zoloft are like insulin, and that by controlling your depression with the SSRI, you're correcting an abnormality, just the way a diabetic would control their diabetes with insulin, and that by doing that, you're going to end up with better results for mom and baby. This is still what's out there and what's getting told to women of childbearing age and the doctors that take care of them, and then pregnant women as well. But that's actually not accurate, and that's not what the science is showing. What the science is showing is that women on these medications, in terms of their pregnancy outcomes, in study after study, they're doing worse. They have higher rates of preterm birth. They have higher rates of low birth weight. They have higher rates of birth defects. They have higher rates of postpartum hemorrhage. They have higher rates of preeclampsia, which is another one of the risks that's important to go over with pregnant women. Preeclampsia is a condition that occurs typically at the end of pregnancy, causing high blood pressure, causing protein in the urine, and it can make moms quite sick. It's a significant cause of maternal morbidity and mortality. Those rates are higher with the use of SSRI antidepressants in pregnancy. And then beyond that, which is the big area we should get into next, is what are the impacts actually on the baby's brain and what are we actually seeing there? So the point of all of this is that the information, and again, our information and regulatory systems are broken, but that information that's been getting out to pregnant women in the public and doctors who care for them has not been correct. And this is over decades. This notion that they don't affect the baby and they're basically safe in pregnancy, that's not really what the science is showing.
I can imagine the faces of some women and moms and dads too who are walking in with these women. I can imagine how shocked some of them must feel or must be when they hear actually there's much more to the story than you've been told. Let me sit you down and let's have a real conversation about this. Because I know if it were me, well, I mean, I, I'm probably sitting in a different seat now where I would be throwing all the information out at them. It's different, but hypothetically speaking, like if it were me and I was just going in and sort of, just just doing what I think is best, and taking care of myself to whatever knowledge I have, and then to be told that what I was doing and the fact that it was told to me that it was safe is maybe not as safe as the information I was given. I mean, that's a shock, I think, for people. And I feel and it's like to no fault almost. Yes, we have to do our own research. Yes, we need to be, obviously, right? This is it right here. We're talking about it. Like, you do need to really step up and educate yourself more, and all the things. But in the same breath, it's like, we should, keyword is should, be able to rely on the experts because they're the experts, right?
Yeah.
I mean, that's real. That's the ideal situation. But as we've
Yeah.
been sort of beating the dead horse for
Yeah.
the last hour, it's like clearly that's not the world that we're living in. So yeah. Um,
Hopefully, though, hopefully, and this is an effort that I'm part of right now, trying to get a petition out to the FDA, which is to try to change the labeling and make it clearer to patients this information about what the actual science is showing in terms of altering fetal development, having an impact on moms and babies. So hopefully, moving in that direction. I will say that the patients who I counsel almost always express that they're grateful that I took the time to go over this with them. And many of them, too many of them, say that they hadn't heard this before. Early in my career, this was when I was a fellow. I delivered a patient, and her child ended up with having trouble early along in the newborn period. Had what we call newborn behavioral syndrome, or other people call it neonatal withdrawal syndrome. The other name for it is poor neonatal adaptation. These rates are high for babies who have been exposed to SSRIs in utero. It depends on the study you look at, and the numbers are all over the place depending on how strict the criteria is. But some sources estimate those rates to be as high as 80 or 85% of showing some effect in the newborn period on babies that were exposed in utero. And so it's a large number of them. Her baby got into difficulty and then ended up needing to go to the NICU. And at that point, I think she went and Googled it or looked it up and realized, wow, this is a very well-known side effect of these medications. And nobody took the time during my prenatal course to counsel me regarding this. And I do remember, this is going all the way back to my fellowship, but I do remember her being very, very upset about the whole situation and upset with her prenatal care team that she had never been counseled about this. And so I think most patients that I counsel are grateful for taking the time for going over this, for doing the counseling with them. And I think it's important with each patient to do this in a way that's not one size fits all, which is kind of figuring out first what their mental health history is, how long they've been on the medications, what's happened with them, their course and whatnot. And also from the get-go, trying to establish that the purpose of the conversation is to inform them, to take good care of them, and not to, again, guilt trip them or pill shame or whatnot. I'm working together with my patients to give them the right information and then allow them to make the choices that they think are best for themselves and support them in those choices.
Yeah, it really goes back to that whole compassionate care, right? You're treating everybody individually. It's not a blanket decision, right? Where you just are going, hey, you shouldn't do this. I mean, that's clearly not even smart because you have to take every individual into account, which I think is super smart. And I know if I was a patient of yours, oh my goodness, I was actually telling somebody that I was interviewing you. I can't remember who it was, a friend. And I thought, wow, if I was in a position and I was pregnant, I would certainly want someone on my team like you, because I still think largely you're kind of a diamond in the rough still. I think it's getting better, but I still think that this is less common than what we see, like largely, or I should say, just in general. Is there
I just want to say that I appreciate your saying that. I
yeah.
also have the luxury as a specialist for having more time with my patients. And I do think two things are working against the doctors in the offices, which is that there is a time crunch, and it is somewhat difficult to go into these in detail when I told Dr. McFillin this, he said, "Look, that's no excuse. You gotta, guys, gotta make sure you go through those." And I'm respectful of that. But I do think that if you compare a doctor who's moving through his or her day, and when a medication question comes up, says that drug's completely safe and effective, that doctor is going to have a much easier time moving through the day than one who is going drilling down drug by drug into the risks, benefits, and alternatives, especially with the number of drugs that our patients are on. So doctors in their offices, meanwhile, want to take good care of their patients, but it's a challenge with modern medicine and the time crunch that can be present often to go into this. The second thing is that there's been so much incorrect information, and the sort of big pharma conventional wisdom, the big pharma scientific consensus has been so powerful and so much drummed out there that so many patients come in with that it's hard to just address that or not or reverse it in the course of one visit. So I think we're working against the tide. When patients come in, on the other hand, who have been informed, better informed, and aren't buying the big pharma consensus, and they understand and they get it, like, oh, that's probably what I'm hearing, probably is not accurate, and probably it's designed to increase sales and profits for big pharma. It's much easier to kind of get through that counseling and for them to understand what the science is actually showing. So I think my colleagues mean well, and I think that they want to take the best care of the patients, but I think the information even the doctors are getting is not correct. And I think also the time crunch and time pressures in the office really work against having good, thorough, robust conversations about these things.
You bring up a really, really good point because I think it's a huge mountain to climb. And I can imagine being a practitioner, right? And kind of like sitting down to have this conversation and really someone coming in not having any idea or just really, just never really dipping their toes into looking beyond what they've heard, taking everything at face value. That can seem like a really just a big pile to sort through, right? And to your point too, it's like I did a show recently in the beginning of the year on insurance. And, I had Andy from Crowd Health on, and it's a crowd sharing insurance, like non-insurance, I should say, plan. And we talked a lot about that, the patient practitioner relationship and how strained it is when you're under the thumb of insurance and insurance is in bed with, pharma and blah, 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 blah. And it's just like this huge thing. And it seems like so big to tackle, right? And it's, again, we keep saying it, but it's not that the doctors are trying to get you, but it's
Right.
really that their hands are tied. And so they don't have the time. And when you're not under the thumb of big insurance, a lot of times that doctor patient relationship is not as strained, and there's more time and there's more energy that can be put into the care. So I love that you brought that up. It's a really, really excellent point.
Yeah.
If there's anything
What
you want to say in response before we move forward.
Yeah, I mean, our medical system, unfortunately, if you said, like, what would a medical system look like if it were designed to increase profits for large corporations rather than for patient health? Like, what would it look like? It would look like our medical
Horse.
system.
Exactly.
Our
Exactly.
medical system, unfortunately, and that's what it's doing. It's really doing a fantastic job generating profits for big pharma, for the device industries, for big insurance. That's what's happening. Our health systems are being used to basically increase wealth and power for a certain segment of society, but it's not leading to improved health. That's for sure.
It is not. People like to say, my favorite is actually like gently correcting them, but people like to say, well, the system is so broken. No, it's not. It's working exactly as it's designed. As sad as that is.
This is exactly so you get now when I say McKenna didn't work for 20 years, but it actually did work. It worked to increase profits. These systems that we have are working as designed to increase wealth and increase profit for a certain sector, but they're not working in the sense that what the public means by that is they're not working to improve health. That's right. And unfortunately, that's where we're at and all need to push against.
Yeah, absolutely. Oh, we could just keep going on that. It's just, it's hard not to because it's really like the elephant in the room, right? There's this huge problem standing in the way. But, people like you who are trying to disrupt things in a good way, in a diplomatic way, and in a real caring way. I mean, you guys are the difference makers. I
The
just want to,
last
no, go
The
ahead.
last thing I just if I appreciate your saying that. I want to be a difference
Of
maker.
course.
You as well.
Oh,
Just in the for the importance of complete or counseling, the one area that I didn't talk about. So we talked about the miscarriage, the birth defects, preterm birth, the preeclampsia, postpartum hemorrhage, the early newborn problems. The big question I get asked about again and again now is what are the long-term effects
that's
or
what I
what
was
are
going to ask you. So you're here. You're here. That's
perfect.
where I was
What
going.
are what are the long-term impacts? And honestly, we don't really know the answer to that. The common sense would be that there's going to be impacts because serotonin plays a crucial role in brain formation. These drugs disrupt the serotonin system, so they're likely to have impacts, long-term impacts. The basic science shows impacts, and then the animal studies do. So if we look at animals who were exposed to SSRIs in utero, we see different behaviors as they get older. So people have said that it looks like anxiety and depression, and they try to do different tests, forced swim models, and all these different behavioral tests. It's hard, I think, but this is what they use as surrogates for anxiety and depression. But they can do things like look at male sexual behavior. There have been numerous studies now on looking at copulatory activity for males who have been exposed to SSRIs during development. And we see for sure differences between the SSRI exposed male mice and rats as adults in terms of their sexual behavior versus the unexposed. So there's less mounting. They do studies where they look for mounting, where they look for ejaculation. They're looking for sexual behaviors, and there is a difference, and we're seeing those differences in the rodent studies. In the human studies, some of the studies are mixed, but there have been several that have found increased rates of autism. There have been a few that have found increased rates of depression, anxiety, another one, problems with motor skills. There's a recent study that came out showing increased rates of gastrointestinal problems. Now, this makes sense to me because 90% of the serotonin in a human is in the gut. And so, if you disrupt the serotonin system in utero, which is what the SSRIs do, could it have an impact on the formation of the fetal gut and then later problems? Absolutely. So, they find increased rates of gastrointestinal problems in the children as they grow up. And then we're seeing the question about longer term issues with things like autism, ADHD, et cetera. People ask to me, could it affect things like personality development? Could it affect things like sexual behaviors in adults? I think certainly that's possible because those tracks get laid down in the brain during the fetal period. And if you're disrupting fetal development, disrupting the development of the brain during the fetal period, could that have ramifications in adulthood? I think certainly that's possible.
Yeah. Wow. I just couldn't help but think when you were just explaining that. By the way, that's a lot to think about or a lot to chew on too. I can't help but think too if there's people listening that maybe had the experience, of maybe being on a medication while they were pregnant and then hearing it now, or maybe putting puzzle pieces together. You might even experience that in your own practice and life, like people who in hindsight are looking back and going, "Oh my goodness." But I think what came to my mind was just how absolutely I can't even fascinating. I don't even know the word. I mean, it's just exceptionally made. We are so beautifully designed, and the human body is so just it's a miracle in and of itself in the way that we develop and the way that we come into this world and all of the things and the reactions and the chemical, everything that goes on. I mean, I don't even have the proper scientific terms. I'm just, talking off the cuff here. And when that's disrupted to any degree, knowingly, or not unknowingly, it doesn't, no judgment here, but there's bound to be trip ups. There's bound to be things that take place. and that our body really does know exactly what to do to sort of facilitate the like the correct
Yeah.
outcome, and when we go in, again, no judgment, this is not a judgment statement, and we tinker with that, with whatever. It doesn't have to be SSRI, it could be whatever, it could be, over vaccinating, as within weeks of a newborn baby coming into the world. There's bound to be things that occur. And so when you were sharing that just now, and I kept thinking, like, wow, it's like the more things we do, the more interventions we give, the more stuff that we mess with, the more mess that we sometimes have. Again,
Yeah.
no judgment, just hearing it, kind of hit
Yeah.
me.
Yeah, no, for sure. Human biology is really complicated. Human biology is complicated. The way everything works, all the reactions that have to take place.
Yeah.
And then I'm thinking about this all the time because I'm watching fetal development every day in my office as the babies develop through the pregnancy, and it's really complex. It's really complicated. And so I think it's important for us to respect the design that's there and also to have humility, more humility about what kind of chaos and havoc we can create by trying to come in with various interventions. And that's not to say that we should never have a medication or we should never have a procedure. That's not at all. I'm not a nihilist with that. But to be careful in every instance, to be thinking that there may be more to this. It may be more complicated than we think, and that we can absolutely cause more harm than good. I mean, the history of medicine has been a series of progress in some areas, but also a series of instances where we were causing more harm than good, where we didn't have enough humility and respect for the biology and the natural processes of things.
Beautifully said. And I wholeheartedly agree. Oh my goodness. As we sort of taper down here, where do things stand now with you? So you've kind of, or you're going, I should say, you're making motions and notions towards the FDA. You're trying to get the labels changed. Are you working with other people? Are there other doctors that are kind of like side by side with you? What's the status of this now? And what do you want to see on the labels of these drugs?
Yeah, I think there's a growing group of people that are becoming aware of this and trying to advocate for it and push it forward. I think the big key will be to get the change on the label, a clearer statement from the FDA. What I would like to see, I'm in the works with a group to try to put forward a citizens petition. Once that petition is out there submitted to the FDA, there'll be opportunities for people to be able to write letters of support to that. They'll open up a docket. And so that's something that people always ask me, is there a way to help with this? I think that once we actually get this officially submitted to the FDA, that then people can join in to try to lend support to the effort. I think the best thing that the FDA can do is to just make this clear to patients in a simple statement that there is evidence that these alter fetal development and have an impact on moms and babies, an impact on the pregnancy, and then to spell that out with some of the risks that I've reviewed here. There's enough research now that we're seeing along these lines that the patients really need the warning in a variety of areas, but particularly with fetal brain development. I think that we now have numerous studies from the basic science to the animal models and now into human studies. There have been now, by my count, 11 human studies doing MRIs on children or adolescents who were exposed to SSRIs in utero. And we're seeing things like smaller brains, lower brain volumes. We're seeing changes in what's called functional connectivity in the brain. We're seeing these alterations. So there's enough evidence now to be able to warn the public that SSRI antidepressant use during pregnancy, there's evidence that that will alter fetal brain development. I think by putting a label like that on the medications, and then by people being aware, it puts that issue on the table, and it also allows patients to understand this and physicians to review that with patients to actually get that information out. So I'd like to see that. I'd like to see a labeling change. And then I'd like to see also our groups, whether it's the NIH or NICHD, or even some of the major professional societies, look at this again and make more of an effort to push or promote uh, full counseling for women in this area. Because right now, I think most women are just getting this, what I would call the pharma conventional wisdom or the corporate scientific consensus, which doesn't reflect now what the current evidence is actually showing.
Yeah. Actually, what I wanted to ask you too, which is I'm sure going to be a question by some, is that what if you're postpartum and you're breastfeeding and you want to take an SSRI? Because I feel like that's a really sensitive time for women and a lot of women, right? Like postpartum can be really tough. And I would assume that there's a good number of women that actually go on SSRIs. So is there a risk with breastfeeding?
Yeah, so there's a lot to talk about actually with postpartum and even addressing your question with patients during pregnancy. This whole message that we've been discussing is a separate question. So I, I just want to tease this out for a second. There's really two questions that we're trying to get at. One is, do the drugs have they been shown scientifically to impact the fetus, impact the pregnancy? So that's one question. That's a scientific question that we can come up with a scientific answer. And I think the answer is yes. These SSRIs have been shown to alter fetal brain development and impact mom and baby. So that's one question. The second question, though, people often will jump to as I'm talking about question one is, well, should a given patient stay on it, come off it? What should that given patient do?
Yes.
That becomes much more complicated because of this issue of withdrawal. And that's then becomes an individual choice and decision for each individual patient where they have to weigh their own experience with it. These drugs, and I should have gotten into this earlier in the
No, it's
conversation,
fine. I should have probably brought it up because I actually have it noted here too.
these
Yeah.
these these drugs have a lot patients have a lot of trouble coming off these
Yeah.
medications, especially if they've been on it for an extended period of time. There can be real withdrawal phenomenon with this. And so people now are talking more and more about deprescribing and tapering. I think they use the term hyperbolic tapering or parabolic tapering, taking really micro steps down in order to not run into trouble with withdrawal. So this then becomes a major issue with the counseling during pregnancy, this issue or phenomenon of difficulty in coming off of them, which is why this conversation that we're having, the warnings, et cetera, really need to get out to the public and to women of childbearing age. Because by the time they get into my office or the time I'm seeing them, whether it's 6, 12, 20 weeks along, that's a difficult time to have that conversation or make that decision. So I just wanted to make sure I had addressed that because what happens when I start talking about question one, do the drugs alter fetal brain development? Do they impact mom and baby? People will often interpret that as saying, as question number two should, and they'll often interrupt me and say, my sister was on these and she tried to stop when she was 14 weeks, and they'll tell an awful story. That's a separate question, what an individual patient should be doing. And I think that needs to be addressed on a case by case basis. To answer your question in terms of postpartum, postpartum is a difficult time for patients. Their hormones are changing. They've got changes in their family dynamics now. They're taking care of the newborn. Sleep,
Sleep.
which is so crucial to mental health. Sleep is so crucial to mental health, is in short supply in the postpartum period. So a lot of women have difficulty during that time. What should a woman do with her SSRI at that point? Again, that becomes a case by case discussion with the patient. If you ask, do they affect the baby? Can they affect the baby through breast milk? The answer is yes to that. So it does look like some medication gets into the breast milk. It does look like some medication gets into the baby. For each mom baby pair, that amount is going to be different. We don't actually know what the doses that get through over to the baby, we really don't know their impact. We tend to say, oh, they're small doses and that they're small for adults. That might not have an impact for adults. We really don't know when those that amount of chemical starts occupying the receptors in the baby's brain or in the baby's body. So we really don't have that information. So can there be an impact? There can be. We think there's also benefits though to breastfeeding, other benefits. So typically the advice is to for the pediatricians and the mom to pay close attention to how the baby's doing. There are numerous reports of symptoms or issues in breastfed babies. They're scattered in the literature. They call them case reports, but there are a variety of case reports. There's one well-known one where a mom was on Zoloft, was breastfeeding, and her baby, I believe it was a preemie, I think it was 33 weeks, was having significant difficulty. I think it was somnolence, and I forget some of the other symptoms, but the baby wasn't doing well. And when they checked the baby's blood level, they found an adult level of sertraline in the baby. And so then people wondered, why was that? It just might have been that that individual mom pair, that the mom may have happened to concentrate the drug in her breast milk, or the baby, the way the baby suckled, the way the baby broke down the drug, also did not was not able to metabolize it. I think that baby also had a genetic not abnormality, but one of
Like
these
component.
component to it where it broke down the drug less. And so that can certainly be present there for any drug. That's a known case report. But there's a variety of case reports like that where then when the mom stopped breastfeeding, the symptoms went away. So what's going on there? Like I said, probably for that given mom baby pair, there's drug getting into the breast, maybe more so than for another woman. And for that baby, they're getting more of it into them and maybe breaking it down less. So that if the moms are on them, then the babies need to be, watched carefully. But it's not risk free per se. There is exposure going on during breastfeeding for the baby.
Yeah. Wow. I think the overall message, and I understand that this is just not going to be the case, right? Because everyone's got their individual experiences, individual choices, lots of things, right? Everyone's got a very layered life. But I think that the overall thing that you are really trying to hammer home is that you want to see the labels and everything changed with more informed consent being given, because women and family, couples, they need to be aware of this before they are trying to conceive or before they're walking in the door of their OB appointment. That is really the end all be all goal. Now, of course, that is just, it's never going to happen 100%. I get that, right? Because people will come back and be like, well, that's just not reality and that's just not real life. But I think with your efforts and other people who are in the game here, that's the goal is to get as many families and women as possible to be aware of this information before pregnancy occurs, because it's a lot easier to tackle than say, okay, now we're 24 weeks in. How are we going to potentially wean this during pregnancy? Or what should I do? I've been on it for whatever, and I feel like I just want to cut it out, but I don't know if I can. Whatever. There's probably just like so many different circumstances. But end all be all. Let's get the information out to people before anything happens in terms of pregnancy.
That's right. And more than half of pregnancies are unplanned. And so it really does need to be information that gets out there into the general public. The spread of information in a society, though, is a fascinating thing, how that works and how information gets to people. But a key first step is for the scientific bodies, the regulatory bodies, to correctly identify this, correctly label it. So I think that's the FDA's role here to change the labeling and make it clear what the studies are showing. And then from there, that gets out and it makes then the individual physician's job in the office or the individual obstetrical provider, whether it's a midwife, a nurse practitioner, a medical assistant, it makes their role or their job much easier at that point because you've now got the information known in a more widespread fashion. Whereas now we're dealing with the reverse, which is so many patients are coming in with what isn't the accurate information, and it's much more difficult to try to get that accurate information out in the context of a visit.
Yeah, yeah, no, I totally get it. It's like you're trying to prevent the fire. You're not trying to put the fire out. You know what I mean? For lack of better example, it's like it's just it's so much easier for you guys as providers when things are laid out appropriately, but you're often working in reverse.
Absolutely. So when patients come into your office and they say, my understanding of the Zoloft that I'm on is that I've got a serotonin deficiency. I've got low serotonin. This is like diabetes. It's correcting my serotonin deficiency. And then by normalizing my mood, this then leads to a better result for myself and for the baby. It doesn't have any effects on me essentially and or on the baby. Like that's not accurate. That's not what the science is showing. And to try to counsel that at that point is a big ask. It's a challenge in the office. Whereas if this information, if the labels get changed and the information gets out there, and I think it is, I think people are getting this information out there by having it on podcasts and things like that, by people discussing it and trying to make this known to the public. By getting it out there, it spreads, it diffuses that information so that pregnant women can have the right information.
Yeah, beautifully said. Are you hopeful that this is something that's going to be happening sooner than later? What are your thoughts here as we sort of, I would say like last thoughts, last sort of statements. Are you hopeful? What do you see happening in the next, say, 6 months, year?
I am hopeful. I always try to stay. I've been I've been active in this area for like 20 years now, so it's got to change sometime.
You're like, don't even ask me that. Of course I'm hopeful.
It was like McKenna. Honestly,
Yeah.
McKenna, I had been sort of arguing or outspoken against for 20 years, and then finally things changed enough. It got pulled off the market in 2023. So I am hopeful, and I think things are moving in the right direction. We have a new administration, and we're seeing there are some changes. There are some differences. Compared to prior administrations, and we're seeing some changes at FDA, at HHS, and I think these are steps in the right direction. And so, hopefully, with these changes and with more attention on this, we are going to see things move in the right direction. So, I am hopeful. I am hopeful about this.
I'm hopeful. I'm hopeful. I'm hopeful for you. I think, well, it's just so admirable, because here you are just like doing your thing. You're in private practice. You're super busy. You've got all these patients. You're delivering babies. You're still, and then on top of it, you've sort of taken on this, passionate task because, and not because, you've been told, well, this is what you got to do, but because it's literally in your heart to make some sort of a positive change. And not everybody has it in them to do that, or they might have it in them, but they just don't take the steps. So, I mean, it's beautiful. Kudos to you for being someone that actually takes the step and does the thing, because I think a lot of us, we know what we should be doing, or we know that we should be, speaking about something, but it seems insurmountable. Like, how can we do this? But sometimes it just takes one person to start. And here you are, so it's beautiful to see. And I'm just, I'm honored to even be 0.05% of it by, having a conversation to where it can just be, more well known that this is actually something that people should consider, and that it should be on everyone's radar, not just SSRIs and not just, pregnant women and families, but really it's about the overall picture of no matter what
Yeah.
you're taking, what your how much faith you have in your conventional doctor or your doctor, you need to be aware of all the information, and most of the time you're not.
Yeah, no, that's exactly right. When you understand it in a specific model with SSRIs, you can understand it more broadly, how the system is working or not working, and then become more aware of these things. No, I really appreciate your kind words in saying that. I think for some of us, we just can't. Some of us have an activist streak and just can't not say something when something like this is going on. When patients are coming in, and as I said, this is happening to me really day after day or week after week, where patients are coming in and they're just not having the right information. And it really makes me feel like, I've got to say something. But you are contributing, and I appreciate you're giving me the opportunity to come on the show, get the message out, promote this to people, and raise awareness. I think you're having a big impact that way.
Oh goodness. I believe me, I don't thank you. I'm so humbled that you even say that, but I mean I'm nothing compared to
Say
compared to
that.
what the work that you're doing. Trust me, I am nothing, and I'm just blessed to be a bridge to elevate a voice like yourself because it's absolutely, it's God's work, and I just couldn't be more humbled to even have the conversation to begin with. Where can people learn more if they want to, or are you active on any social media platforms, or how could they get in touch with you if they wanted to? Where can people find out more in any way?
Yeah, most of what I do is put the studies up. I have an X account, a Twitter account at Adam Urato 1, and that's where I put the studies up regularly. And that's mostly what I'm doing on that account is putting up the studies. It surprised me how much interest there is just in putting up scientific studies, how much interest people have in following me and passing the studies around as they come out. I think one thing that really surprises people looking at my account is how often these studies are coming out. Sometimes it's two in a week. They're coming out regularly, and this has been going on for the last 20 plus years, where we're seeing study after study that are pointing in this direction. So if people want to follow these studies, that's where they can and they can see what I'm up to on Twitter. My kids tell me I need to be more active on Instagram or TikTok or something like that. I guess I'll have to figure
Hey,
those out.
maybe I was going to say maybe you need to incentivize them and have them start an account for you. And then we can throw that in the show notes too. Hey, if that ever happens, you just let me know and I'll be happy to add it in because people listen to these shows for, these episodes, maybe a year, 2 years later. So you never know.
Great.
But
Okay, great point. I'll let you know.
yeah,
I
let me
thought I had
know.
to I thought I had to know how to dance to do TikTok
Oh
or
no,
something.
trust me,
So
please no, you definitely don't. Because I've got a little TikTok account for the show, and I'm definitely not dancing. Maybe I should, maybe I get more engagement. But anyway, my friends, as always, like I say, I will put Dr. Urato's, I always want to say Twitter, but his X account, I will put that into the show notes. And if there's any other links, I will also put those in the show notes for you. If you have, any trouble, as I always say, don't hesitate to reach out. I'd be more than happy to point you in the right direction. It has been an absolute joy having this discussion with you. It really has. And plus, I have learned a lot as well, which is just an extra blessing. It's like there's no greater blessing than being able to learn with all of you who come on and just so eloquently share with your wisdom and all of the knowledge. And it's really just been a joy. So thank you so much, Dr. Urato, for being here.
well, it was my pleasure, and I really appreciate your having me on. As I said, I really appreciate your getting the word out.
Oh, the pleasure is mine. All right, my friends. Until the next episode, I hope that you all have a very blessed day, and I will see you all soon.